Nope, I am. I
Oh, yeah.
trying to figure out how to share my screen here so it goes up to the right one. So
Michaela's right here too. She can.
So if you have like your PowerPoint open,
no,
Oh.
I can figure that out. I'm trying to make sure I share it to the right screen. So when I look, I'm looking at the PowerPoint and the camera.
okay,
So
we're seeing your
it's-
desktop right now.
Okay.
Look, no ice houses.
That was that is Saipan overseas. So I have the opportunity to teach over there every once in a while. So
Well, Travis, I was gonna start with that, why it's important about kids and airway thing, and then hand off to you, and then I'll sit here and jump in and we'll just tag team it. That makes
Yeah.
sense?
oh, that sounds great.
Yeah. I don't know about you folks, but I learn a lot
We're
better.
seeing your
and I think
desktop
adults
still,
will learn a
Travis.
lot better when you get real world stuff put in. Makes it make a lot more sense.
There we go. We have a presentation.
So do you want me to go ahead and get rolling here?
Yeah, you could go ahead and start.
All right, here's the story of Dr. Owens and his first day as an intern. Back in the day when the interns, everything rotated over, July 1, every year was considered the most dangerous day in American healthcare. Because that's the day medical students became interns, interns became residents, and residents become attendings. Get it? You don't want to be in the hospital on July 1. You get all the newbies. So I started my residency program down in Iowa before I got recruited for the rural train track in South Dakota. And I'd been an EMT, which probably might have saved this kid's life. I don't know. Was an Army medic before that, all that kind of thing. So I get called down to the ER, St. Luke's down in Iowa. And I come in and the ER doc is sitting there and said, yeah, there's another RSV kid down the hall. And parents went off to get the kid registered, and they'd come in from a small town outside of Sioux City and just signed off to you. Walked in the room, and here's this kid about yay big, about that long. This is pre-Braslow. Now you kind of know where I'm heading with this, right? We had a horrible RSV outbreak in 1993. I mean, it was nasty. We had CDC dogs in Iowa, South Dakota, whatever. So I walk in, you know, you're trained to do a history and a physical. This kid, the EMTs have done a great job. The people that had stabilized the kid up in some small town in Northwest Iowa had done a great job. The EMTs have done a great job. Hit the door of a level 2. And they took the oxygen off, and they took we used to use a lot of nasal saline, that kind of thing. And then the key factor here with the kid is there's nobody else in the room. No SATO2 monitor. Remember this little kid, this little baby, retractions. And I look around trying to find something, and I look down, and the kid stopped breathing. Anybody ever had that happen to you? Well, you get a little bit of sphincter tone right now, I'm here to tell you. So I'm in a hospital. I don't know where the peds ICU is. I haven't even gone through introduction to being there. So I scooped this kid up, and luckily there was a pediatric crash cart I could grab, an ambu bag with peds face mask on it. And I go cruising down the hall, and the Sergeant Owens voice came out. Make a hole. I'm going down at shift change with this kid like this, bag, screaming, where in the hell is the peds ICU? Apparently that kind of stuck with me through the rest of my career. I still have nurses down in Sioux City every now and then. I run into them, and it's kind of a sight. So what's the take home from that story? Kid turned out well, really good. I got up to the floor, and they thought I was a pediatrician, and I finally just said, no, I'm a first day intern. And I thought the nurse was gonna like stroke right there, and all of a sudden I had anesthesia, PICU, neonatologist, the whole team showed up, right? As soon as the word came out, first day intern, it was just like all hands on deck. So anyway, what is the take home from that story? is kids, first of all, do really good. We're up here, we're starting to get in trouble, we're starting to get in trouble. Bam, they quit breathing on you. For old guys like me, we sit there and go, I'm getting short of breath. Right? Older people go more like this. Kids can compensate. Wham, you're done. Number two, leave the monitors on until you physically hand off that kid to somebody else. And don't let them take the monitors off. You watch them take your stuff off and put their stuff on, and never lose eyes on the kid. And I know it's getting tougher and tougher. We got rigs out there now running with nothing against volunteer firemen, nothing against CNAs, but we got to get this out to them that when you start, if you got a kid on oxygen, the kid's screaming, that's great. Screaming kids, good. Kids that are quiet, kids that are retracting, kids that are starting to not really breathe as deep, that's not good signs. So first take home is never trust a kid unless you got eyes on them. Number two, make sure your handoff is the kid is not left in the room, because they can't speak for themselves. They can't say, Dr. Owens, I can't breathe anymore. They just quit breathing. So now we have a little bit better monitoring stuff. Remember back in the day, sometimes we'd even have to put finger saddle twos up on the ears. And then the last take home on that is make sure you're calling ahead. If you're coming into a smaller hospital like a Redfield, you call ahead and you say, hey, we got a 6-month-old here not doing well, because we're going to have the whole team there. Because it takes a whole team to take care of these kids. So makes sense why that story makes sense. They crash and burn on you. You got to keep an eye on them. You got to do your interventions early. And I'm going to turn it over to Travis, and I'll sit over here on the stool and jump in whenever Travis wants me to, and maybe sometimes when he doesn't want me to. And welcome to today's lecture.
Thank you very much. So I apologize. Michaela had asked if I would be willing to come up to Aberdeen, and we're doing our statewide EMT skills lab opening today. So we've got a couple sites throughout the state that we're kind of helping to try to facilitate that with. And then also I was in Worthington last night doing an EMT refresher. So unfortunately I wasn't able to make the trip up there. So I hope everybody's doing well. The topic today is just pediatric emergencies, but more specific pediatric cardiac arrest. But the question always is what causes pediatric cardiac arrest? And so there's a multitude of things that can contribute to it. And, when you think of cardiac arrest, we generally are most commonly encountered with adult cardiac arrests. So pediatric cardiac arrest in the out of hospital setting is an infrequent encounter for providers. When it does happen, it is, I would say, life-changing because it's not something that we generally practice with, or it's not generally something that I'm going to not even say look forward to, but it's not something that we want to experience. But it's something that does happen on occasion. And so with that pediatric cardiac arrest, we look at, well, what's really the main contributing factor? Why do kids go into cardiac arrest? And the reason is it's impaired respiratory function. And so the respiratory lecture is going to kind of lead into the pediatric cardiac arrest. I see that there's a multitude of people here online, and I believe that there's a number of people in person up in Aberdeen. So one of the things I'm going to really approach this, and this is something I've taken home and kind of remember from 30 years ago, going through paramedic school, was a pediatrician said you cannot be a good advanced provider until you're an excellent basic provider. And so I think the emphasis of this particular presentation is going to be coming back to our basics and making sure we do a good job managing the airway, managing ventilation and respiration, and then hopefully preventing cardiac arrest from occurring in the out of hospital setting if it hasn't happened. And then we'll talk through how to manage it if it has happened and you come across that type of a call. From a disclosure perspective, I do have financial interests in Teleflex, which is a medical device company I do clinical education for them periodically throughout the year for vascular access devices. The biggest thing that we generally ask individuals, anytime you participate, listen, attend a pediatric lecture, generally the presenter will ask, are you comfortable taking care of pediatric patients? And generally, I would say overwhelmingly, everybody says no. When we do simulation and outline facilities, hospitals, EMS agencies, we ask that question. Are you comfortable doing a pediatric scenario? Unless this is the patient population that you're working with day in, day out, your comfort level, your confidence level is probably going to be a little bit less than the normal population of patients that you generally take care of. So with that in consideration is, we generally ask people, what causes you to be uncomfortable? What's the, what factors contribute for your confidence level to not be where it needs to be? And so generally what people will say is, I lack pediatric education. Well, today you're participating in pediatric education. The National Registry, the state education programs, pediatric education is always a component of the education that you have to complete. But again, it's a small percentage of the overarching topics that you need to complete from a continuing education perspective, and it's a couple chapters in the EMT textbook, it's a couple chapters in the paramedic textbook, so it's not that it's a focused component. But when you look at the educational piece, there's a multitude of classes that are out there that you can attend to gain, gather, obtain more information on managing the pediatric patient. It's kind of, if you get caught in a situation that you're not comfortable with, generally it forces you into getting more information, getting more knowledge about that. So if it happens again, you don't have that uncomfortable feeling. So again, with the topic today, we'll talk about pediatric cardiac arrest, but really we're going to talk about pediatric respiratory as well, as far as how we can prevent it from occurring. Dr. Owens kind of related to the fact that kids compensate and they compensate well, but when they decompensate, it's abruptly. And so that's the piece we also want you to be attentive to, is that yes, it might only be a 15 to 20-minute ride to the hospital in the back of an ambulance, but with a sick kid that has been sick for several hours, that kid could potentially decompensate on you during that transport. That might be the point of time in this clinical situation where that kid decompensates. The other thing too that people talk about is the frequency of exposure, the infrequency, of EMS calls. And I didn't look up the statistics on this from a state perspective just to see how many EMS calls, in the state are pediatric related. If people aren't putting in the right data, then you're not going to be able to obtain the right data. But generally speaking, it is a small percentage of EMS calls for any entity, unless you're doing pediatric specialty transport. So if you think of yourself, kind of close your eyes, think back in history and time, when have you transported pediatric patients? In the totality of ambulance calls that you do, when have you transported pediatric patients? And generally speaking, they're usually far and few between. Maybe a motor vehicle crash, maybe a bicycle crash. But in the medical condition and medical situation, thanks, Corolla, 7,000 to 8,000 calls per year for pediatric patients out of about 100,000 calls. So maybe 8%, 10% of the calls in the state are pediatric related. And so when you think of that, it is a small percentage of calls, but when it is a medical emergency, generally the parents will transport that patient to the clinic. Generally, the parents will transport that patient to the hospital. So when you get an EMS call that is pediatric specific for a medical emergency, generally that kid is going to be sick. They're going to be, maybe it's a hypoglycemic event, maybe it's a febrile seizure event, maybe it is an unconscious event, maybe it's cardiac arrest. But nonetheless, it's the kid is going to be sick at that point in time. And so it's not that the kid is going to be happy and playing around, and they're going to visually appear very, very ill. And that's the concerning piece, is that they're in that stage of time where they can clinically decompensate quickly on you. The other thing we hear is that, we're not familiar with the equipment because we don't get a chance to work with it because we don't do a lot of pediatric calls. And so the emphasizing point there is that responsibility comes back to you as the provider. If you want to be an EMS provider and you want to be a great EMS provider, you have to practice with the equipment that you have. And I think, and I'll kind of reference to Dr. Owen is you practice the way you fight. That's what the military emphasizes, is that if you want to be an excellent soldier, you need to practice as if you're in combat warfare. And, you can't practice, with by just looking at pictures. You need to get the stuff out. You need to touch it. You need to know where it's located at. You need to know how it functions, how it gets put together, all of those pieces, because it is an infrequently used item. Because of that, excuse me, because it is an infrequently used item, that's what we want to focus on, is making sure that you know where it's at, how it gets put together. The other piece that we run across so frequently is that something gets misplaced. So you, in your best intentions, you're going to put it together to use it on an ambulance call. But the problem is that the last time somebody had it out, the parts and pieces didn't get put back together. So it's the accountability piece as well, is to make sure that if you are using it, and taking it out and looking at it and doing an inventory to make sure all the parts and pieces are there, make sure it's going back into the bag so that all of those parts and pieces are there for the next person that might have to use it. Unfortunately, if you have a bag valve mask, but you don't have the mask to go with it, it doesn't do you a lot of good. Or if you have the mask and you don't have the bag valve device, it doesn't do you a lot of good. So making sure you're going through from an accountability perspective, to do a really good, thorough inventory on your pediatric equipment. I know EMSC in the past has given out the Braslo bags to EMS agencies. The challenging piece is it's also the agency's responsibility to replace those items once they've been used. When I was traveling more frequently doing EMS education, one of the things I always emphasize is, let's look at your EMS bag. Let's go through and look at it from an inventory perspective. What airway equipment do you have? What oxygen administration equipment do you have? What BVM ventilation equipment do you have? A lot of times with the airways, what I would find is they generally come in an 8-pack or a 9-pack of oral airways. There'd be 2 or 3 of them in a little Ziploc bag and an EMS bag, and that was their airways. And so they were like, well, we've used the other ones, so we won't reorder them until we use the rest of them. And so if you use one airway out of the little box of 8, then you need to reorder a new one so that you have the appropriate sized airways for all of those patients. If you use the oxygen delivery device, you want to make sure that you're replacing it. It's not ideal. Could you use an adult non-rebreather mask on a peds patient in a pinch? Yes, you probably could. But we want size appropriate equipment so that it best serves the patient to the clinical needs that they have. The other thing too is we talk about unfamiliar with disease processes and clinical situations. There are a multitude of clinical anomalies with clinical conditions for pediatric patients. With the Children's Hospital here at Sanford, we see a lot of children with cardiac conditions, malformations, and underlying genetic disorders, special needs kids. And so I think that in general also causes a lot of discomfort for EMS providers, hospital providers, because they're just not familiar with the clinical course of some of these disease processes. From an EMS perspective, we understand, we know what hypoglycemia is. We understand and we know what seizures are. We know what that looks like. But it's also, we generally see that in the adult population. So it's that scary moment of, well, now it's in a pediatric patient. It's in a 3-month-old, it's in a 2-year-old, it's in a 5-year-old, it's in a 15-year-old, it's in a newborn. Those are the situations that we're not comfortable with, because again, pediatric calls in themselves are low volume. Now, out of those 5 pediatric calls, you run per year, now you have a 3-week-old infant that's seizing, or you have a 3-week-old infant that's not breathing. And that is probably one call in a lifetime that you will experience. It's not something that you experience on a day-to-day basis of a nursing home interfacility transfer for a UTI. It's not a motor vehicle crash that you're responding to out on the interstate. It's that infrequent volume and the infrequent exposure to that clinical condition. So I would say anytime you have the opportunity to gain education, to expound upon your information on different pediatric diseases. The other thing that I would also encourage you to do, and I always tell students, is there's nothing wrong with going back and looking at your EMT textbook. Even if you've been out of it for 20, 30 years, that's fine. Go back and look at it just to refine the knowledge, information, and skill set that you have to manage those pediatric patients. Most of the pediatric courses that you take, whether it's PEP or pediatric emergency care or PALS or ENPC, whatever it might be, whatever that course might be, they're going to give you a textbook, and generally speaking, they're probably in the ballpark of about 200 to maybe 300 pages long. Yeah, it's a lot of reading, but it provides a profound amount of information from content experts that wrote those particular chapters in the book. So it's going to provide you some more information. The other piece is unfamiliar with the anatomy and physiology of pediatric patients. As mentioned before, is pediatric patients have the ability to compensate and compensate well, but they abruptly decompensate. So that abrupt decompensation is what we're generally not prepared for. And so I had somebody, just kind of verbally tell me this the other day, is they're like, 1 minute you look at a peds patient and yes, you know that they're sick and they've got a heart rate of 150 or 160 and they're breathing 40 times a minute. Yes, they're gray or ashen and cyanotic and you've got them on oxygen, and you turn your head to go grab something and you turn around and they're apneic, or now all of a sudden they have a heart rate of 40. And so, yes, they do decompensate that quickly. And so one of the emphasizing pieces that I always emphasize for any clinical provider is that you have to cognitively think in your head, what's the next thing that's going to happen to this patient in 5 minutes and 10 minutes? And if you think that this kid is going to respiratory arrest in the next 5 minutes, then you should be in the process of caring for this patient, getting out your bag valve mask, getting it connected to oxygen, testing, making sure that your intubation stuff is going to work, that the lights work, the batteries work, that your suction is working. If you're thinking it's going to happen, then you want to get all of your stuff out and ready to go so that when it does happen, you're properly prepared for it. You don't want to find out that there's no suction catheters with the suction device when you actually need to suction the patient. You don't want to find out that the batteries are dead in the intubation equipment when you have to go intubate the patient. So that pre-planning piece, and we emphasize this in neonatal resuscitation for newborns, is that you should be testing your equipment before the event even occurs. And so if you're anticipating that this kid's going to have some clinical demise or compromise, you want to plan for that appropriately and get that equipment out urgently. The other thing we hear a lot is that with the special needs population, some special needs patients in the past have been institutionalized. A lot of these kids have been now moved back into the communities. They're being taken care of and cared for in the home. And so the exposure and probability of transporting a special needs patient increases with likelihood because of this transition in healthcare. And so you're going to see kids that are vent dependent. You're going to see kids that are have learning disabilities. You're going to see kids that have feeding tubes. You're going to see kids that have VP drains. You're going to see these kids that have some of these clinical devices that are attached to them that help them with their activities, daily living, or they help them in their survivability in day-to-day activities. Wheelchair-bound children, the inability to maybe communicate effectively with a special needs patient. And so throughout the entire course of dealing with a special needs patient is knowing where your resources are. So if this child is in the school system, maybe it's the school nurse, maybe it's the teacher that's going to be that guardian or informational source for that particular patient. Maybe it's a care provider at home, maybe it's a parent, and so generally we feel as an EMS provider we know a lot about a little bit about a lot of information, or maybe a lot about a little bit of information, but the parents of these children know the child best. And so you should be reaching out to them and asking. It's not that you don't know anything about special needs patients or you don't know anything about caring for a special needs patient, but the parents or the guardians are going to know the nuances on how to manage that. And so having the parents in the back of the ambulance, you might have a policy that there's no ride-alongs in the back, but if you do not know how to run a pediatric ventilator, putting the parent in the front of the ambulance is not in your best interest. Having the parent in the back of the ambulance running that pediatric ventilator while you're caring for the patient is going to be in your best interest and the patient's best interest as well. So use your resources wisely in those particular cases. family affiliation with patients with or similar patients, basically. And so, when you look at that component of it, I talked about this last night in EMS refresher, is this kind of PTSD exposure of maybe you've had a adverse bad pediatric call in the past. Maybe you have a child or grandchild, or a neighbor or a friend's got a child that looks very similar, same size as the patient that you're taking care of. And so it's difficult to disconnect yourself from the visual kind of memory piece of that and then care for the patient that you have immediately in front of you. And so I remember several years ago, we were resuscitating a pediatric trauma patient from non or intentional trauma from abuse. And one of the nurses just kind of broke down and she walked out of the room. And afterwards I checked. I said, you kind of left, and I saw that she kind of emotionally broke down. But I said, she's like, this kid looked just like my granddaughter. And she's like, I have a granddaughter that's 3, and I just, every time I looked down at this child, I kept on seeing my granddaughter. And so she's like, it hit me, where I wasn't expecting. And so sometimes that's also going to be the difficult hill that we have to climb, is overcoming those emotions. But again, we're there to do a job. We're there. The patient is dependent upon us. And so the emphasis there is seeking out professional help, after the fact, so that you're not carrying these skeletons in your closet for these types of calls. The other thing too is just the underlying clinical nature of the call, whether this is a trauma patient or whether this is a medical patient, or if it's a cardiac arrest patient. It comes back to a little bit of knowing a little bit about the clinical conditions. But the other thing too is just the familiarity with the underlying clinical conditions or circumstances of the event. Maybe this is a bad trauma call. Maybe this is a car versus pedestrian call. So it's just, that exposure of what potentially complicates your comfort and confidence level in caring for a pediatric patient. Just kind of emphasizing again, just from a special needs perspective, these are just a couple pictures I pulled from the internet last night. And so again, how do you transport these particular patients? What position do they need to be in? Is there any, continuous medical equipment that's attached to them from a special needs perspective? If the patient has learning disabilities, communication disabilities, how are you going to be able to effectively communicate with it? Generally, your kids are going to respond differently based upon maturation and cognitive function throughout their lifespan. But when you look at that, as well as if you have some type of underlying disability, that may impact your ability to communicate effectively. The other thing too is that we look at, and very simplistically, trying to keep things very simplistically, is if you were to look at these 3 children, one of the things they emphasize, and I think it's coming up in the next slide, is the sick, not sick analogy. And so we have to look at the children as, do they appear happy and well? Do they appear ill? Do they appear, sick? And so that gut instinct, that door assessment of the patient and situation is going to help us. When we look at EMS related calls, we simplistically break them down. Is this medical or is this trauma? We focus on the primary assessment of airway, breathing, circulation, and neurological status. I always emphasize, if you have a patient that's unconscious, they have the inability to manage their own airway. They have the inability to manage their own airway. There's a high probability that they're going to have some type of an airway occlusion that we're going to have to intervene in. If they have an airway occlusion, they're not going to be able to breathe effectively, so we're going to have to take over ventilation for them. If they have ineffective ventilation, they're probably going to have a cardiac compromise as well. So that primary assessment is super important to be able to do that effectively, be able to do that functionally, and be able to know what is just around the corner from an assessment perspective and how you're going to have to intervene. The secondary assessment is going to be important as well, just from the standpoint is we need to do a thorough head-to-toe examination. Yes, when you do your trauma assessment, you do your DCAP BTLS, you do your assessment, on medical patients by asking a lot of questions and kind of progressing down through your head-to-toe assessment. The other piece is understanding and knowing what some of those questions are that you need to ask, but it's also to understand, what disease process might this child be going through. Is this an asthma event? Is this a bronchiolitis event? Is this a pneumothorax, for example? Is this some type of a GI disorder? Is this a neurological disorder? Is this a febrile event? Is this a septic event? So having an understanding as far as what that disease process is that's causing this clinical condition for the child. The other thing too is we have to make decisions from a clinical management perspective. We have to have clinical judgment. We have to have clinical decision making. We have to have critical thinking as well. And so when you're looking at that clinical decision as far as how you're going to manage this particular patient, one of that is kind of it's premised on what are our protocols allow us to do, or what does our protocols tell us that we need to do in this particular type of situation. We're managed the patient for a short period of time from in this out of hospital setting, from potentially home to hospital. So that transport time could be as little as 5 minutes. It could be as much as maybe an hour. And so in that period of time, what do I need to do to clinically care for this patient to prevent their clinical condition from decompensating? So that decision making, might be oxygen administration based upon your skill level. It may include vascular access. It may include defibrillation in a cardiac arrest situation. It may include airway management. It may include continuing some type of clinical interventions that the patient had at the home. Maybe they're on tube feedings, for example. And so we have to take those things into consideration as how are we going to manage this patient during that EMS transport on the way to the hospital. As I mentioned before, we kind of break it down. Is this kid sick, not sick? We use a pediatric assessment triangle. The other thing too, we always ask, what's your level of pain? Well, sometimes kids don't numerically know on a scale of 0 to 10 what that pain is, but we can also use the Wong-Baker FACES pain scale to have them point or show us, how much discomfort they are actually in. The other thing too that and this was kind of an experiential thing, is that kids acquire, yes, they understand that they're in pain, but it's an acquired response of how they need to respond to pain. And so I remember back, I had probably a 5-year-old kid that got hit by a car, had bilateral femur fractures, which in itself is a serious condition. But when we arrived on scene, the kid was just kind of sitting at the curbside with a bystander, just sitting there, weeping, yes, crying, yes. And scared, yes. And when we initially got there, he kind of looked and he said, "My legs have an owie." And yes, I understand that. I can see your legs are you have bilateral femur fractures. That's a bad situation for a pediatric patient. But I said, this kid is not acting normal based upon the circumstances and the situation. And then the mother come running down the street, frantic and screaming and yelling. And then the kid said, "Well, apparently I need to, cry and break out and stuff like that." Yes, there was probably a little bit of psychological distress, that the kid, in shock that the kid was going through, but it was also that learned response. Yes, exactly. Culturally acceptable response to pain. And so, the kid was like, "I know this hurts. I know I need to cry, but how much should I cry?" The other thing too is if you feed into it, and they see that you're comfortable and confident with it and reassure them, then the emotional kind of exposure, the emotional recourse that you're going to have to deal with is going to be a little bit different as well. Pediatric assessment, things that you really want to be able to do is break it down is, do you know what the nature of illness is? What's the underlying thing? And so I had a EMS crew come into the ER one day, and I said, "What's the patient's chief complaint?" And they said, "They're unconscious." And I said, "I understand they're unconscious, but what's the chief complaint? What's making them unconscious?" And they're like, "Well, they're unconscious." And I said, "I know that, but there's got to be something that's making them unconscious." That's our responsibility as an EMS provider, is to at least try to figure that out. Is this a hypoglycemic event? Is this an ingestion event? Is this, a febrile event where they have a high fever? Is this, trauma? What exactly is causing the unconscious signs and symptoms that we're encountering? Because we have to treat the underlying condition, not necessarily the signs and symptoms. So we have to understand what that underlying condition is. So if it's hypoglycemia, then we need to treat with sugar. If it's hypoxia, then we need to treat them with ventilation and oxygenation. So having an understanding of what that underlying condition is, what that nature of illness is going to be important. The other thing, same thing as with mechanism of injury, is understand Is this a car versus pedestrian? Is this a appropriately restrained child in a car seat? Is this a bicycle accident? How fast was the bicycle going? Is this a fall? Is it a fall down the stairs? Is this intentional or non-intentional trauma? So we have to understand all of those factors. I always imagine closing your eyes and imagine what the event that the individual, the patient went through to acquire these particular injuries in a trauma situation. If they're unrestrained in a vehicle and they were ejected, I want you to think of what a car driving down the road is at 55 miles an hour, and that patient getting ejected through the window, through the door, flying through the air, bouncing on the ground, rolling, and then the car coming down the ditch and rolling over the top of them. That's the stuff you want to be able to visualize to understand what the mechanism of injury is, because it's going to help you anticipate what things you need to deal with from a trauma perspective. It's going to explain why they have the injuries that they have. So again, treat it with a high index of suspicion on a trauma condition, and then also on the medical conditions is continue to ask questions. If you're not going to ask questions, you're not going to get to the root of the problem. And so the more questions you can ask, the better you're going to be from an assessment perspective. When I think of any type of an assessment, you're as an artist, you're starting with a blank white canvas, and the more detail you put into that canvas, the greater the quality of the picture is going to be. And so if you're putting just a little bit of information on that canvas, you're going to end up with a stick figure. But if you put a lot of information on that canvas and you're asking a lot of information, you're gathering a lot of information, you're doing your sample history, you're doing your OPQRST, you're doing vital signs every 5 minutes, you're going to throw a lot of information on that canvas, and you're going to have a phenomenal portrait that you're going to be able to convey over to the hospital once you get there, because it's going to have a lot of detail in it. The other question I ask, and this is a loaded question, so the answer should be yes, but are pediatric deaths preventable? Are pediatric injuries preventable? And I know Corolla's on here, and I would imagine she's going to be capital letters, exclamation points. Yes, pediatric deaths are preventable. Pediatric injuries are preventable. And why? It's because as adults, some intervention wasn't integrated into caring for that patient. It wasn't integrated into managing that patient. It wasn't integrated into protecting that patient. For us as EMS responders, again, going back to one of the first slides, is what makes us uncomfortable in caring for pediatric patients when they're sick. Well, imagine as a parent that has no medical information, we have information, we have knowledge that can recognize whether the kid is sick, but a parent might not have that information, so they might not recognize that the child is sick. So what might be obvious to us, like, I can't believe you didn't call the ambulance, this kid's got a temperature of 105. Well, maybe they're not familiar with what that temperature, where that point is at, where they need to call for help. I can't believe that you would let this kid sit on the couch here for 3 days, in an unresponsive state with nausea, vomiting, diarrhea, and not take them to the hospital. They might not understand the complexity or severity of the clinical condition that the child is going through. Yes, it's that information gathering to be able to prevent situations like this from occurring. That's the important piece that we want to be able to focus on. And again, I think Dr. Owens talked about this at the beginning, is that you have pediatric conditions, pediatric patients compensate, but the description is they compensate to a particular point in time, and when they decompensate abruptly. So they basically fall off the cliff. It's our job to put our hand out and prevent them from crashing. We want to be able to intervene with our clinical care in the out-of-hospital environment and complement that with what the hospital is able to provide. Dr. Owens emphasized, if you're transporting a patient that is clinically complex, they're sick, you need to be reaching out to the hospital ahead of time so that they're properly prepared to receive that patient. One of the tools that many of the EMS agencies in the state is receiving here in 2023 is the Avella eCare system in the back of the ambulances. If you have a clinically complex patient that's sick and you're in that phone a friend phase of, like, I don't know what to do next, you should be pushing the button to activate that so that you can get some clinical resources. Clinical resources that you have, and I love to see this getting in the back of ambulances when we do transports, is there's pediatric reference charts on the wall, there's burn charts on the wall, there's what do I need to tell the hospital in a rating report? There's all these reference charts, these references in the backs of ambulances, and that's great to see because what are normal pediatric vital signs based upon age and size? Generally we know that vital signs are a little bit lower than adults, but what exactly should it be based upon that particular age? The Brasil tape is what equipment do we need for this particular size patient? How much does this patient actually weigh? All of those factors kind of come into being able to supportively prevent this patient from crashing severely. So the other thing too is I always think of what tools do you have in your toolbox to take care of pediatric patients. I always kind of jokingly say God gave us a bunch of tools to do a good job as a clinician. He gave us our eyes to visually see what's wrong. What is that? What can we see with our eyes before we even touch the patient? What does the patient sound like? Can you hear wheezing? Can you hear coughing? Do you hear gurgling? Do you hear nothing at all in a case of really complex asthma? What are your ears telling you? The other thing is what do you smell? What do your hands, what do your hands, what can they touch? What can they feel? What do you smell? Do you smell that fruity breath? Can you touch and sense that this child has a fever and you can feel the heat permeating off of them? Is it cool skin where it's, shock and hypoperfusion? Is this a kid that's diaphoretic where maybe they're hypoglycemic and diaphoretic? Do you feel crepitus? Do you feel distension? Do you feel rigidity? You're using your hands to use that as assessment tool as well. Your nose, yes, you're smelling. Is this patient incontinent of urine or feces? Do you smell that fruity odor, from their breath where you're concerned where it's DKA? Have they gotten into some type of a chemical where you're smelling some type of chemical exposure? So we're, using your senses. Now, the other thing I always kind of jokingly say is that you shouldn't be licking patients because patients don't necessarily appreciate that. Some people probably would pay you to do that, but you shouldn't be licking patients. And so, but from a sensory perspective, your eyes are going to tell you a lot. Your hands are going to tell you a lot. Your ears are going to tell you a lot. Now, the other thing we have is in the back of the ambulance is we have $200,000-$300,000 worth of equipment in the back of an ambulance that's going to help us take care of this patient. The ambulance services are receiving new cardiac monitors. That cardiac monitor has the ability to tell us what the heart rate is, what the O2 sats are, what the respiratory rate is, what the blood pressure is, what the O2 sats are, what the end tidal CO2 is. It has the ability to give us that information. However, the important piece with all of these types of tools is you need to still treat your patient. You can't constantly be focusing on the equipment and not paying attention to your patient because your patient is going to tell you, present you with information, signs and symptoms far before the fancy expensive equipment is going to provide that information. You're going to be able to pick up on that. Now you need to kind of pair that cognitive information you're getting in classes and pair it with your physical assessment that you're doing on the patient. So you need to recall back from the textbook to say, hey, fever in newborn infants is a bad thing because their hypothalamus isn't developed and they don't have a fever, a thermoregulatory system, an intact thermoregulatory system. Or you need to know that kids have a high metabolism. And so if they're very, very sick, they're going to burn through sugar really, really quickly. And so we should be checking blood sugars on these patients to know, is this also a bad clinical condition that's also a hypoglycemic event as well as one event stacked on top of another one. We do glucose testing. You got your pen light, you got your stethoscope. And then again, just from the telehealth perspective is you have that as a tool in the back of your ambulance as well. That stethoscope, especially in respiratory patients, is in general, pediatric patients are breathing a small volume of air in. So you need to be very, very attentive as far as how you're listening. Theoretically, a very quiet environment as possible so that you can listen to the air exchange that's occurring in that child's chest. Dr. Owens, it kind of emphasized this before, is a silent, quiet asthma patient is a sick asthma patient. They're not taking enough air in to even make the bronchial passages wheeze. And so that's a very grave finding, very serious finding in your pediatric patient is that, oh my gosh, oh, this kid mustn't be doing that bad because they're not wheezing. No, they're not wheezing. This kid is really, really sick because they're not able to take enough air in and actually cause the wheezing sound because of the turbulent movement of air in the bronchial passages. The other thing too is from your assessment standpoint is this a medical event or is this a trauma event? And these are my particular numbers that I always emphasize, when I teach patient assessment for EMS providers. But if you're doing a trauma assessment, 80% of that trauma assessment is hands-on and 20% of it is questions. You're going to ask questions. You're going to do a very thorough hands-on assessment. You're doing your DCAP BTLS, but there's more hands-on with trauma patients than there is questions. In contrary, medical patients have more questions, and then you dig into the hands-on assessment. So you're going to find that 80% of your assessment in medical patients is going to be questions. And don't ask those just yes or no questions. You need to ask questions of detail. Where are you having pain at? Describe the pain to me. It's not, are you having pain? Yes, I'm having pain. But then you have to ask more questions. So ask detailed questions about the information that you want to gather. Write that information down in a tablet so that you can correlate or pass that information on to the hospital. Can you describe how long this has been taking place? We have acronyms that help us gather this information: sample history, OPQRST, DCAP, BTLS, DOTS, CMS, PMS. There's a multitude of acronyms that you can use to gather this information. And you should be writing responses down for everything that you're able to gather. The other thing that we look at as we get into pediatric respiratory emergencies is we ask the question is, why is this occurring? Why are these ensuing respiratory events occurring, and what is contributing to this pediatric cardiac arrest? Well, one of the things is probably hypoventilation. And so it's not necessarily hypoventilation from a rate perspective, but also from a volume perspective. Are they able to take in an adequate amount of air into their airway passages, push it down the trachea into the bronchial passages, get it out into the alveoli, and actually make a gas exchange? Are they able to move air down that deep and that far? Just because they're breathing 40 times a minute doesn't mean that they're getting an adequate amount of oxygen or an adequate amount of volume. They might be breathing 40 times a minute because it's a compensatory response. So one of the things is you have to look at the effectiveness of their breathing. We always, from CPR, is, are you ventilating the patient adequately? Do they have chest rise and fall? So when you look at your patient just from a native respiratory function, is, do you see adequate chest rise and fall with the respiratory effort? The other thing is that if they're breathing 40 times a minute, that is a physical activity that's going to be draining them of energy. So at some point in time, they're going to be clinically fatigued from breathing that fast. But more importantly is just the assessment of how much volume are they able to take in. So if you look at the graph over on the right, there's a couple different size patients that are there. I put some different mathematical formulas there as well. And so if you look at a 6-pound baby, that's approximately 3 kilograms in weight. 2.2 kilograms or 2.2 pounds per kilogram of weight. So just very simplistic for math, divide 6 by 2, you have 3 kilograms. Well, we know that patients generally, when we ventilate them on a mechanical ventilator, we set them up with about 6 to 8, maybe at most 10 cc's per kilogram of air going in to help them breathe. So on a 6-pound baby, 3 kilos, they would have about 18 cc's of air that they would be breathing in. So if you think of the whiteboard markers, that people write on whiteboards with, those are probably in the ballpark of about 12 to 15 cc's each. So in this particular patient, their total air that they're going to take in with a breath on a newborn baby is basically a marker that you're going to use on a whiteboard. So not a lot of air. 60-pound child, 30 kilograms, which is kind of at the verge or end of the Brazlo tape from a measurement perspective, will take in about 180 cc's of air. So if you look at a pop bottle is generally about 500 to 600 cc's. So you're looking at, in this particular case, about a third of a pop bottle. That volume has to be split in half. Half of that volume is going to the right, half of that volume is going to the left. So you're getting about 90 cc's of air going to the right lung, about 90 cc's of air going to the left lung, more specifically a little bit greater in the right than the left because the left lung is a little bit smaller in size anatomically. But when we look at that volume, you have to look at is there's not much air going into this patient to actually make that gas exchange if they're breathing in a hypoventilated state. So that's where our interventions from oxygen administration we're giving them high concentration of oxygen, but we also need to be able to give them the volume to get down to the alveoli to actually make the gas exchange so they're not hypoxic. That hypoxic component is that impaired oxygen exchange. That's where it's happening at the alveolar level. But the other thing is do they have an intact cardiovascular system? If they're hypoperfused, they have a low blood pressure, they're tachycardic, and they have no systemic perfusion. The question is how well is their cardiovascular blood flow distribution? About a third of your blood flow sits in the arterial system, about 2/3 of it sits in the venous system. So the oxygen is getting transported on the hemoglobin, the red blood cells, in that arterial system, and about a third of the blood supply sits there. So if they're hypoperfused and they're not perfusing, getting blood supply out, maybe they're a trauma patient, they're bleeding out, that might be contributing to this hypoxic event as well. It's not that it's a ventilatory issue. It might be just a simplistic hypoxic issue because they're in an anemic state. There's not enough blood supply there to transport the oxygen. The other thing that we look at is what could be causing this is the anatomical changes that occur with different types of diseases or also trauma. And so is there swelling of the airway passages such as asthma or bronchiolitis that's preventing the air movement down to the distal branches of the airway passages? Is that what is causing this particular complication? Is there swelling in the airway structures because of an anaphylactic reaction? Is there burns, to the airway that's preventing the movement of air? Is there turbulence in the airway passages? Is there secretions in the airway passages, mucus in the airway passages that's preventing that effective airflow? The other thing I mentioned earlier is that if you're breathing and you're compensating for a prolonged period of time, there's at some point in time there's going to be muscle fatigue. The kids don't have a great store of energy, fat store of energy, and so they can burn through metabolically their energy stores very, very quickly. And so at some point in time, that's where you see that respiratory failure, is that they decompensate quickly because they run into this muscle fatigue and they have the inability to effectively breathe at that persistent rate that they probably need to breathe at. If your body has, from a respiratory perspective, it has a minute volume expectation. You generally figure minute volume out is how much air you're able to breathe in with one breath. We multiply that times the respiratory rate. That's your minute volume. That's what the body expects to take in and move out every minute of time from a volume perspective. So if you take in 20 cc's of air and you multiply that times respiratory rate of 20 times a minute, you have 400 cc minute volume. That's what the body expects. If it's not getting that, it has to change something. It has to change the respiratory rate and breathe faster, or it's going to have to change the volume of air that you're taking in with each breath and breathe slower. And so it's going to have to do something. But if you're not getting that minute volume rate that you need, then the body's going to have to breathe faster. When it breathes faster in these kids, they fatigue out much quicker as well. The other thing too is we look at the actual rate. We talked about the hypoventilation and the volume, but it's that rate as well. And very simplistically, is it normal? Is it slow? Is it fast? Or is it not there at all? And so we know, just simplistically based upon textbooks, I think they say pediatric patients are 15 to 30 times a minute for normal respiratory rates, 12 to 20 for adults, and I think 25 to 50 for infants is the numbers that are in most of the EMT textbooks. So, is that patient breathing within those normal parameters? And then when you look at those normal parameters, we also have to look at, are they at the upper limits of fast? Or are they at the lower limits of fast? And if they're at the upper limits of fast, what's causing that? And we have to get to the root of that particular cause. But if they continue to breathe fast, what's going to happen in the next 5 minutes? Do I need to do something different clinically? And if I do, I need to get that equipment prepared so I can manage the situation when it actually occurs. We look at diseases that cause respiratory failure that lead into cardiac arrest. So asthma, allergies, any type of environmental exposure, hypothermia, hyperthermia, kids getting locked in the back of vehicles, accidental or intentional poisonings, ingestions, cardiovascular abnormalities, rhythm disturbances. We were talking last night at the EMT refresher with high school kids having cardiac anomalies and cardiac arrhythmias causing them to go into cardiac arrest. I know that has happened multiple times around the state, unfortunately. And you know, and even last night, one of the EMTs that I was working with, he said I was watching the football game when the NFL football player collapsed, and he said it immediately took me back to one of my high school football players that collapsed on the field, and he said one of the other coaches and I ended up having to do CPR and use the AED on them. And he said that's the first thing that came to my mind. And he said that event happened 8 years ago. And so those cardiac anomalies, unknown cardiac anomalies that lead to rhythm disturbances, can lead to a lot of these contributing factors as well. Any type of sepsis that occurs with pediatric patients. The other thing too that we're seeing in the pediatric population is the increased probability of clotting disorders post-COVID exposure. Any type of endocrine disorders, so hypo or hyperglycemia, known or unknown diabetic complications. One of the nurses I worked with in the past in ICU, she said, you know, I am a horrible mother, but she said, I'm even a worse nurse. She's like, here sat my son for the past 3 weeks in DKA, and I didn't recognize the signs and symptoms that were right in front of my face. And she's like, but I go to the hospital on a daily basis and take care of patients in the ICU that have DKA with blood sugars in the 5, 6, 7, 800s. And she said, I know how to manage those patients, but here sits my son for the past 3 weeks with a blood sugar greater than 800. And she said, I couldn't see the symptomology, even though the signs and symptoms were right in front of my face. And so she felt horrible about that. But on the same token is that sometimes we know this, and the parents know it, sometimes not. So you have to put the pieces of the puzzle together to say, hey, this kid's going to the bathroom quite a bit. They're drinking quite a bit. They got this fruity odor there. They have dry skin. They're fatigued. Man, it seems like signs and symptoms of hyperglycemia. So it's being able to put those puzzle pieces together. Seizure activity, whether it's an epileptic neurological condition or maybe a febrile event as well. There's a large number of febrile seizures that occur with pediatric patients. They always talk about it's the speed in which the temperature rises, not necessarily the temperature that it gets to. And so when we look at that piece, that is a very scary situation for a parent, a child, or a family member to go through. And so it might simplistically be just a febrile event, or, you know, in the worst case scenario, it could be some type of a neurological disorder. It could be a tumor. It could be something else. And so we have to be able to look at the root cause of what the problem is. Is that seizure activity leading to hypoventilation? Is that seizure activity leading to a low respiratory rate that will contribute to the patient going into cardiac arrest? We talked about trauma prior. So is it blunt or penetrating trauma? Is it intentional or non-intentional trauma? And then also just looking at the mechanisms of injury. So impaired oxygenation, decreased respiratory reserve, plus increased oxygen demand will lead to respiratory failure risk in pediatric patients. They just don't have a lot of respiratory reserve. They're breathing fast, they fatigue easily, and so they can decompensate quickly. So what we do is we want to look at the airway structures of this pediatric patient. Is there anything contributing in this patient's current clinical condition that's going to compromise their ability to breathe effectively, and then also prevent them from going into cardiac arrest? So we look at the heart rate, the respiratory rate, we look at their blood pressure, we understand they have increased metabolic function. We also look at their neurological status. Your brain needs sugar to survive, your brain needs oxygen to survive. So if it's not doing that effectively, you're going to have an altered mental status. If you have an altered mental status, it impairs the ability to maintain a patent airway. That patency of the airway is also going to be influencing the quality of respiratory function you have. And if you're not getting oxygen in your body, your cardiovascular system is going to collapse. So the root of the cause for these pediatric cardiac arrests, a lot of times is in the multitude of times is going to be respiratory disease that's not managed. So we have to be able to key in, pick up on this immediately so that we can intervene. Sometimes we can prevent it. Sometimes we need to treat it. Sometimes we need to intervene and use other tools in it as well. Airway management, and just to emphasize, this is always covered in the EMT textbooks, but just emphasizing positioning of pediatric patients in a neutral position. versus an improperly placed position. So you can see the padding rolls behind the head or behind the shoulders because of the large occipital area behind the head to put them into a sniffing position. And you can also see the picture of the child that's laying flat, supine on the back with the large occipital areas causing him to be in a hypoflex position, chin to chest position. So it compromises their airway status. We also have tools so we could do manual positioning of the head, so padding, head tilt, chin left, jaw thrust, but nonetheless, we have to put a little bit of padding behind the shoulders to get that child into a neutral position. The next question is does this child need to be suctioned? Is there any secretions in the airway that need to be suctioned out? Do you get kids, if you look at bronchiolitis, sometimes the kids that we admit to the hospital, put in the ICU, we end up intubating, putting on ventilators. It's because of their inability to manage their own secretions and the contributing factors of respiratory failure and fatigue and the hemodynamic status of them, but it's that inability to manage their own secretions. So does the patient need to be suctioned because of vomit or blood or airway secretions that they have? We have access to nasopharyngeal airways and oral airways. So again, make sure your airway boxes are appropriately stocked with the right size airways. I think for nasal airways, there's 15, 18 different sizes of nasal airways that you can potentially use for patients. You also have to look at are they effectively used based upon the anatomical structures of that particular patient? Do you have the lube that you can effectively use on that particular patient as well? I think I've seen an increased number of eye gels used across EMS, across the state, across the region. So that seems to be a very popular airway device, supraglottic device used by EMS providers. But if the patient has a gag reflex, then what are we going to do from an airway status? Are you positioning them in a semi-Fowler's position? Are you putting them in a recovery position? How are you positioning that patient to effectively manage their airway? You can get into advanced airways, surgical airways, based upon skill set, whether it's paramedics or you're getting to the hospital. And then we just look at just airway management for these patients in the out of hospital compared to in hospital setting. We have a very small environment that we work within. We have a limited access to the type of equipment to take care of the patient's airway or ventilatory status. It differs from what the hospital has access to. So we need to be able to make do with what we have in the back of the ambulance and prevent things from getting worse and hopefully improve the patient's clinical condition as things happen. We also look at, are we able to effectively oxygenate the patient if they're in a hypoxic state? Are we able to effectively ventilate the patient if they're in a hypoventilated state? And so again, having the appropriate device and the appropriate equipment to manage the patient. So bag valve mask devices matter. So if you only have an adult bag valve mask in your ambulance, that's generally 800 to 1,000 cc's. If you go back to managing that patient's airway for that 3-kilogram patient, that patient needs 20 cc's of air. So how can you effectively ventilate that pediatric patient, that infant, with an adult BVM? So you need to have size appropriate equipment. So when we look at our infant BVMs, they're generally 250 cc's by volume. Pediatric bag valve masks are about 500 cc's by volume, and then our adult BVMs are generally 800 to 1,000 cc's by volume. High flow oxygenation, as we're assisting ventilation and providing oxygen at the same time. There's different oxygen delivery devices that you can use as well. Nasal cannula, simple mask, non-breather mask, high flow, CPAP, Venturi mask. There's a multitude there. Generally, again, when you think of transporting a child in the back of an ambulance, maybe aside of a motor vehicle crash, bicycle accident, some type of trauma, in the medical conditions, these are kids that are going to come to you infrequently, and when they come to you, they're going to be sick. So being able to effectively oxygenate them and ventilate them to prevent the ensuing respiratory failure and cardiac arrest is going to be imperative. The other thing too is just what identifies clinical improvements. That's obviously, if what you're doing isn't working, then the question is what do I need to do differently to improve this condition? And so textbook wise, it emphasizes the need to reassess the patient every 5 minutes if they're clinically unstable, every 15 minutes if they're stable. But again, it's an evolving assessment that you're doing. You should be able to see this in real time, whether this patient's improving or not improving. Sick kids are limp kids. Sick kids are not acting normal. The kids that are playful and active generally don't generally have a life-threatening condition, but it's the kids that are not reacting, not responding appropriately. They're limp, they don't have good tone, they're not interactive, they're not looking around, they should be crying because you're a stranger. All of those factors contribute to determining how sick this child actually is. A little bit, we talked about this earlier, is just airway structures, what the bronchial passages look like. So I think this is a bronchiolitis, just with the narrowing of the airway passage in the bronchial passages, the inflammation, the secretions that's preventing oxygen and air getting down into the alveoli and actually making that gas exchange from being able to take place. So what can you do to improve oxygenation and ventilation for the patients is doing a very good thorough assessment, oxygenating them, preventing them from going into respiratory failure, respiratory arrest, using your BVM device, positioning the patient, managing secretions, and then effective transport to the hospital. Early notification as well. Different types of respiratory diseases that lead to respiratory failure and also ensuing cardiac arrest. More specifically is that if we're not effectively managing these as a healthcare provider, as an EMS provider, if they're not getting recognized and they're not getting treated appropriately, it's going to lead into continued deterioration of the clinical condition for this patient. And again, some of it is related back to the equipment and resources that you have to manage the patient. Sometimes it's just the recognition of what's truly going wrong with the patient as well. But when we look at admissions to the hospital, generally respiratory emergencies is the number one, or some underlying issue with respiratory emergencies is the number one cause of hospital admissions for PEDS patients. There's still other things, such as neurological disorders, hematological problems, endocrine issues, or trauma, cancer. Those factors are all there as well. But when we look at it as, respiratory failure leads to hypoventilation, leads to impaired neurological function, and then ultimately leads into cardiac arrest. So cardiac arrhythmias, sudden cardiac arrest, most of the time is about 2/3 of the cases are actually related to some type of underlying cardiac event that occurs with the patient. Sometimes these are known, sometimes they're unknown. Also, trauma is going to lead to cardiac arrest. And so again, unprotected trauma, or if you just look at mass and velocity, such as a car versus pedestrian accident, children have anatomical structures that are soft and pliable, and so they don't protect the internal structures of the body as well as an adult patient. As an adult, our bones are rigid and are intended to break, provide some protection to protect our internal organs. In pediatric patients, the bones are softer, so the internal structures are more susceptible to blunt force traumas. The other thing too, and again, I emphasize this, is not digging into the situation deep enough to understand what's going on with the patient. And so it's the uncorrected medical condition that leads to pediatric cardiac arrest. And so knowing and continuing to dig into what's wrong with it, if you're not seeing improvements in the clinical condition, don't just accept it for face value. Continue to dig, because this kid might have 2 or 3 things that are going wrong. It's just not the one thing. And so it's that uncorrected clinical condition, or recognizing the clinical condition that can lead to it. The other thing too is just from a safety perspective is we talk about leading causes of death, and this is a staggering number, is that annually about 251,000 people die in the United States because of medical errors or medical mismanagement. And so again, coming back to this particular slide, is if you're not recognizing what the underlying problem is and you're not treating it correctly, it's going to contribute to this child being one of these particular numbers. And so that's where that emphasis of education, personal commitment, skills training to learn more about how to manage these patients, how to manage the special needs patients, how to manage respiratory failure patients, and to prevent the cardiac arrest from actually taking place. From a management of cardiac arrest, it's dependent upon your scope of practice and what you're allowed to do from a medical director perspective, what's in your protocols, what's in your guidelines. I think once the cardiac arrest occurs, the clinical management of the patient is spelled out fairly clearly, I should say. And so we're, from a basic perspective, we need to do airway management. We need to assist ventilations. We need to provide compressions to provide perfusion. If your patient is large enough, you can use the Lucas device to provide mechanical compressions. If you have the ability to do an advanced airway, that might contribute, to the patient's improvement as well. But it comes down to just being good at the basic skills: airway, breathing, circulatory support in these particular cases. We have a tool that becomes very important in cardiac arrest conditions, and it's the use of the defibrillator. But one of the things that you'll find is that, unlike adult patients, the pediatric heart is not necessarily a diseased heart. They haven't had the extra hamburgers with super cheese on it and all the grease and that kind of stuff, and the greasy fries, and the fast food. They haven't had that. Now, obviously, sedentary lifestyles and obesity is an increasing concern across the United States. And so that is leading to more pediatric related cardiovascular deaths just because of obesity and diabetes. But when you look at the clinical management of a cardiac arrest patient, it's generally spelled out. The American Heart Association does a good job in their basic life support, as well as advanced cardiac life support, but more specifically pediatric advanced life support, as far as what the treatment algorithms are for a patient in cardiac arrest. Surprisingly, you'll find that in pediatric cardiac arrests, it's generally bradycardia, electrical mechanical dysfunction, EMD, or PEA, pulseless electrical activity, some type of an electrical dysrhythmia that's not producing some type of perfusion. It's not necessarily that, like the adult patient, that you might find a patient in VTAC or VFib. So some of these patients might not be in a shockable rhythm. So yes, you have an AED, but when you attach the AED, it says no shock advised. It's probably because they're in a bradycardic rhythm, or they're in a pulseless rhythm that is in a non-shockable condition. And so generally the reason they're in that particular condition is because they have an uncorrected respiratory complication. They are in that cardiac arrest because they have become hypoxic, they have become hypoventilated, it contributed to cardiovascular collapse. And so that's the things that lead to it. One of the things that they emphasize in cardiac arrest is just asking the questions. Why is this particular patient in cardiac arrest? Why is a 3-year-old in cardiac arrest? Is it because the 3-year-old got into grandma's heart pills and it's an accidental ingestion? Is it because the child has had seizure activity and is seized 5 times over the last 3 hours, or the last 30 minutes, and is in status epilepticus and is caused hypoxia and hypoventilation? Is this a kid that has DKA and has a blood sugar of 2200 and has an altered mental status and has electrolyte deficiencies in their body? So we have to ask that particular question. The other thing too is, what contributed to this? Is it a time factor? Is this something that has been brewing over the past 3 days? Is this something that happened acutely over the last 30 minutes or the last hour? But the algorithm of treatment gives you questions that you should be asking. Are there certain clinical conditions that this potentially could be? Is this hypoxia? If it's hypoxia, how do we treat it? Well, you need to do bag valve mask ventilation. You should be doing oxygenation. You should be reassessing the patient to see if that's improving. If it's not improving, then what do I need to do differently? Is this a tension pneumothorax where the chest needs to be decompressed? Is this some type of an electrolyte disorder where we need to give medication to correct the electrolyte deficiency? We can treat pediatric cardiac arrhythmias with medication. Sometimes we can treat them with electrical energy, with cardioversion or defibrillation. Sometimes pediatric cardiac arrest ensues because they have a cardiac rate of 200 or 250 beats per minute, and basically the heart fatigues out and causes arrhythmias. And so we just have to look at the hemodynamic stability of what led to this particular event. Supportive care is if you do successfully resuscitate the patient. We look at that supportive care. Neurological outcome is dependent upon how effectively you oxygenate the brain. If the brain stays hypoxic, there's going to be adverse neurological outcome of the patient. If you can effectively perfuse the patient well by doing compressions, and you can effectively oxygenate the patient by providing supplemental oxygen and ventilation. The intent would be is that you're keeping the brain perfused and decreasing the extent of brain damage that's occurring. We also look at cardiac support, and so is this patient going to be resuscitated in a hypotensive event where their blood pressure is going to be extremely low? Is their heart rate going to be low where it needs to go faster? Does this patient need to be electrically paced? Does this patient need medication to increase the rate? Is the patient going to be breathing spontaneously, or are they going to be apneic? And so do we need to continue ventilation? If we ventilate the patient with a bag valve mask, does that air going into the stomach increase the size of the stomach, pushing against the diaphragm, and decreases our ability to effectively ventilate the patient? Or by ventilating or over-ventilating the patient, does it put air into the stomach and cause the patient to regurgitate or throw up, which then causes an airway complication? And so every action that you do is going to have a potential consequence. And so we just want to try to decrease the consequences that you do and effectively manage the patient. Evaluate the glucoses. We talked about hemodynamic stability, but that's just kind of an overarching, encompassing intent. Evaluate the glucoses is that, again, under physiological stress, kids are going to burn through a lot of sugar. And so, making sure that we're assessing, treating that hypoglycemic event as well, if that's there. And then any type of positioning adjustments. And so does this patient need to be in a, again, supine position, semi-Fowler's position? Do you need padding behind the shoulders to maintain airway patency? Is this patient that should be in the recovery position? What position does this patient need to be in to assure optimal ROSC stabilization? And then what treatment adjustments or equipment adjustments do you need? And so if the simple mask isn't working, by switching to a non-rebreather mask, is that really going to solve the problem? Or, do we need to transition over to a bag valve mask device? Depending upon the patient, maybe this is a high flow oxygen patient. Maybe this is a patient that needs some type of pressure support or PEEP support to keep the alveoli open. So we add a little bit of PEEP to the bag valve mask device. And so again, we just have to be able to clinically make these adjustments in the patient's treatment that we've selected to hopefully improve the patient's outcome and condition. That is it. I apologize for going over. I would encourage you to go out to our website, sanfordemseducation.org. The other thing is our Facebook site is Sanford Academic Affairs EMS Outreach. It's long. I apologize. Marketing picked it, but we do a lot of stuff with our Facebook site, putting courses out there, putting simulation activities out there. If you're interested in the monthly education, we have a grant through Tripp County through SAMHSA that provides free continuing education to anyone that's affiliated with an EMS agency in the state. And so if you're interested in that, send me an email. That is every Monday evening from 6 o'clock to 8 o'clock p.m. And then the first Wednesday of every month, all of our lectures are uploaded to the portal. We've got over 100 hours of pre-recorded lectures. And then again, every Monday evening, we do a live televised lecture based upon the topic. So 4 to 5 times a month, we'll do those lectures. And then also we've got the free EMT courses for individuals throughout the state that affiliate with an EMS agency and work for or live in a rural area. And so those courses are free. We're in the middle of doing our spring, January through May course. We'll do another one starting in August. Again, both the SAMHSA grant and the Department of Labor grant through Redfield and AHEC is providing that educational opportunity for individuals. So, and then lastly, if you're interested in doing mobile simulation, again, reach out to us and we'd be interested in visiting. So thank you for the feedback. Any questions?
I got some chats here, Travis. I'm going to pull those up.
Okay.
I think we covered those. Anybody in the room got any questions for Travis? I'm not seeing any, Travis. You must have covered it.
Hey, I
Good as
appreciate it.
always
Thank you.
do.
Thank you very much. I appreciate it. Anything from Dr. Owens at all?
Yes, stay on.
Okay.
Okay, a couple things. So, the way life is, things. Okay,
Okay.
Kayla wants me to do slides, we'll do slides. So let's talk about oldies but goodies. I see a few of us that are about this age that probably have seen it. Due to people that don't vaccinate their kids for common stuff. Back in the day, we used to have a thing called Haemophilus, caused epiglottitis. As more and more people are not vaccinating their kids, you're more likely to see epiglottitis. Totally vaccine preventable. And I think I've seen 2 cases in, I don't know, I started in EMS in 81. So even back in the day, it wasn't all that common, but it is life-threatening and it will get your attention. So if you come in and you see a kid, say 2 or 3 years old, and they're tripoding, they got both elbows on both knees, they're kind of sitting forward and they're drooling. You put a little oxygen on them. You talk to them really calmly and you put them and you transport them to the hospital on mom's lap, whatever it is. Nothing goes in the mouth. Because what it is, the Haemophilus causes the epiglottis, that thing that hangs in the back of your throat, to get really, really inflamed. And then they get a spasm. The reason why I know this because nurse allowed me to prevent myself to potentially kill the kid. Because I want to take a look, right? Give me a tongue depressor. She said, no, you're going to call ENT, anesthesia's on the way because she nailed it. Bang! That's epiglottitis. Of course, we had to put the kid down and put him right into on a ventilator. But so if you see that, the 3 things is they're tripoding, they look septic, and they're drooling like you wouldn't believe because they can't swallow. The reason why we know that's coming back is because the amount of people being vaccinated for Haemophilus is going down. Another oldie but goodie that doesn't necessarily have to do with peds airway is another oldie but goodie, a thing called polio is coming back. Now this is I've got my my public health hat on. And when I read how they were detecting it, I thought this has got to be, like humor, Dr. Humor. It's not. They study wastewater in the urban areas looking for diseases. And they're starting to see an uptick in wild polio. Because once again, people won't vaccinate their kids for polio. I've never. What's that?
At least they're not autistic.
Oh, don't get. Oh man, I'm not going to jump on that one. But yeah, I'm a firm believer. I think it's because my family comes from dad's side, a bunch of ranchers out western Nebraska. I just think everybody in the chute. That's why I look at vaccinations. But all right, so let's kind of do a heads up. So the on the training side, and this is why I need Travis still here because he's got the numbers. A few years ago, with the in collaboration with Sanford School of Medicine and the AHECs are kind of part of that same club. We were able to get 2 federal grants, one Department of Labor grant, a federal grant, and SAMHSA, another federal grant. Since then, we talked about this a little bit last year. We've co-opted with Egtegra initially. Now I've been doing it with utility companies. I just gave a talk at the joint utility training session. So we're going to get out to all the line men and women. And basically it's a triad of training. And it's meant to be not only training them to be kind of an initial responder, but also maybe to get them to look at possibly going in and linking up and becoming an EMT. Because once again, I don't think the data has changed, folks. 2016, 1/3 of rural EMS agencies reported unable to respond or unable to respond in a timely fashion to a critical care issue. And when you look at the cost of healthcare in the United States, those 2 things don't jive. So on one hand, you have the most expensive healthcare system in the world. On the other hand, rural South Dakota, you get T-boned in certain counties. You're gonna have to wait way outside of that golden hour to get an intervention. So I'm trying to get as much training and then lead that training into EMR or EMT. So what Dakota Responder is, it's three basic things. What we did is we looked at, or I looked at, or somebody looked at, I guess we all looked at it. What are three life-saving interventions that you can teach in 3 hours? Narcan, because our opiate overdose rates are starting to look a little bit more like West Virginia all the time, okay? Number 2, stop the bleed. And number 3, AED. So now we're flipping into the second generation. So this is an early slide of Agtegra folks. And we're out like, I think we've done about 170 Agtegra employees. I think we're up to 30 or 40 utilities, bucket truck people. And I'm gonna go back to the slide back. And look at that confidence in being able to put an AED on or stop the bleed. So now phase 2, yesterday. Once again, the dean of the med school grew up in Ravinia down there by Armor. He is so pro rural EMS, it's just great guy. But anyway, so now we're doing something even kind of, this is kind of out of the box stuff, right? Nobody's doing this in the United States. So we're taking what's called farm program students, frontier and rural medicine. They're based out of, there's a program in Millbank, Spier, Millbridge, Parkston. There's a couple more. Anyway, they've already had that training. And then as of yesterday, I trained them in order to how to train people outside of the healthcare systems or outside of healthcare or non-EMTs on how to stop the bleed, use of Narcan and AED. So if any of you folks are near around any of these training centers where these medical students are at, Parkston, kind of the line here would be Millbank, Millbridge, Spier, and anybody online. Contact, either contact me or contact med school if you want them to come talk to your 4-H groups or your rural fire departments or whatever. Because think about it, folks, Stop the Bleed came out of the Department of Defense. They looked at all fatalities overseas, especially in the Iraq-Afghani theater, and they found that a huge percentage of those people had preventable death. All they need is a tourniquet. And I don't know if you know any folks that have been lately deployed. They're actually sewing the cat tourniquets right into the uniforms because it changes outcomes that much. So we have these student doctors out there that are really fired up. They want to do some training. And what I also would ask, if you have medical students in your communities, approach them and see if they would, I think every medical student, whether they're going to be a dermatologist or a real doctor like family medicine, I think they all should be at least 20 runs rural EMS before. Doesn't matter what they're going to go into. They have to understand what the conditions are out here. And you got a med school that's backing you. So that takes care of kind of the Dakota Responder. So one of the things that we got a phase 2 of this, but we're probably going to run out of funding. So I don't know where I'm going to get funding, but look at the number of people out of that first 100 that took Dakota Responder training that are interested in EMT training. So this is where you can directly contact Travis. We still have money for both dual credit, which would be high school students, to take the EMT course and get both college and high school credit, and then integrate them into your services. Okay, one. There's money also for people just to take the EMT course, cover book tuition fees, that sort of thing. And we've got about another year's worth of funding. Hopefully we can work with legislators. And I would once again suggest you all need to be contacting your legislators about getting funding on this, Because if we can start converting that 1/3 that say they're interested, even into EMRs, because under state law, I believe it's 1 EMT, 1 EMR you can roll. I'm here to tell you, I know people, docs that are practicing critical access, where they're rolling with a volunteer fireman and a CNA. Because we're beyond the point where they can even recruit or retain EMTs. You can't do as volunteers volunteer 300 hours a month. That's just not reality. So we got my program I'm trying to really keep going here is to beef up rural EMS. The start is Dakota Responder. The next step, you don't have to go through Dakota Responder to get the EMT program. Travis, how many EMTs have we got through the system?
Last January, excuse me, last January, we had 160 EMTs enrolled in the program. We had 125 that actually completed it. We had 15 EMTs over the summer that took our summer course. And then in the fall, we had 90 students that participated in the fall EMT course. And we've 225 that are in the spring 2023 EMT course. We had 400 people register for the January through May 2023 EMT course, but we landed at 225 between high school students and our online learners.
So what's all those kind of add up to?
Just shy of 500. So
All
when
right.
you look at probably 1,600 active EMTs in the state out of about 3,000 that are technically certified, you know, it's probably a third of the workforce we've, you know, potentially trained now, getting them to take the test and volunteer, you know, link up into the communities. But, you know, 500 people in the last year basically is what we're looking at.
So now I won't be the most political guy in the room. So if you have a program that just produced 500 volunteer rural EMTs, don't you think we ought to maybe support it? That's where you folks contact your legislators, because looking around the room, we're not 20. That's that next crop that's coming up. And if we got 500 now, and if we could get this show on the road for full-time rock and roll, I'm saying I think we could probably hit 500 a year. I think we can solve this EMT problem within 3 years, because it's been a long time in the coming. And unless we really get on it, think about if it's you or your family that's part of that 1/3 did not get responded to. And when I brought this up a number of years ago to the Medical Association, and I brought that concept up, you've got the backing of the South Dakota Medical Association, Sanford School of Medicine, all the AHECs, and we just got to keep that the funding going. The reason why I say that is our data from our disaster training program. I also run one for people in health sciences, you know, nursing, PA, OT, MD, all that kind of thing. We just did 350 on Thursday.
Wow.
Mass chaos. It's great teaching students how to respond to disaster. But anyway, I think that's a pretty good bang for the buck. You know, we've been at it, about ready to run out of federal funds, but and if we can get refunded, we can keep going. But 500 new EMTs, that's going to affect outcomes, right? So if you have anybody in your agency or anybody in the town you're from, or anybody you think might fit into one of our programs, and with the Fed, you kind of got to, you know, push the square through the triangle sometimes. But get a hold of Travis and we'll see if we can line up some funding for you. Because we still do have some funding, I think, through the next 12 months. As far as Dakota Responder, if you want to get medical students involved with that, probably just get a hold of me through Michaela. And then once again, they're somebody once said that millennials and Gen X's don't volunteer. They do. They volunteer at the same rate that us boomers did, but they do it different. They want to know how long, for how long and how much, and they want it really defined. And that's okay, because that's the way they roll. And what we found with our medical students in general, once they go through the disaster training day, almost 50% of them volunteer to be deployable assets for the state of South Dakota. That's pretty impressive. That's boomer, right? Back in the day when everybody volunteered for everything. So that's kind of where we're at. And let's just punch through these slides quick. So that's that Dakota responder improves, and that's the locations of Actigra. So most of those places have, for sure, in their vehicles will have stop to bleed kits and the AEDs, and the Narcan is pre-positioned in the majority of their major sites. Now everybody's got Epi, everybody's got Narcan in their rigs, right? Anybody not? Talk to me at the break. I got way maybe to get you some Narcan. You need Narcan or what? Okay, catch me at the break. We'll figure out a way to get you some. Wait, next one. Now this is I think this is my final slide. So for years and years and years, the concept of USD School of Medicine is a med school without walls, right? We're everywhere. We're third-year programs all over the state, fourth-year programs all over the state, but we had a ceiling. We don't have a ceiling anymore. That's the Warner grain bins. So I thought this is a good idea. We're going to take these future rural family docs, and Actegra was instrumental in getting this done, and show them high angle and low angle rescue. Remember, show? So I hand them off to their safety officer, and I tell them, okay, everything you learned in med school is wrong. You just listen to what the safety officer tells you, nothing more, nothing less. And I went, oh, wait a minute, I don't have a cell phone. So I walked back to my truck, get it, come back over, and I said, where are the medical students? Those are pictures of medical students being basically tossed off the top of grain bins, because that's how you learn. I'm like, go Actegra, yeah. And so they learn about high angle and low angle and bad gas and no gas and all that. So that's the new reality of medical training folks in South Dakota. And even if they don't practice rural medicine, they will have a much better idea of why in a grain bin accident, that patient's not going to be here in 5 minutes, because you can't get them out of the grain bin in 5 minutes. Follow? So hopefully this will all come full circle. And the other thing is, I'm on admissions for the med school. You ought to see the number of kids in the last 3 years that applied for med school that not only had EMT training, they are EMTs. Excuse me. And I think that's going to change the culture of healthcare. Because if you have somebody that spent a couple of years, Eureka, Bottle, Redfield, Miller, Fulton, Gettysburg, in the summers when they come back from college, working the rigs, and now is a medical doctor, you don't forget that early stuff. At least I never did. I don't think they will either. Matter of fact, they probably have it on Facebook. Anyway, any more slides?
I don't think so. Let's see here.
Yep. And if you ever want to see something fun, you can watch this live. Anybody here ever heard of the Egg Weekly? It's kind of like the Green Sheets. Comes out once a week. TV show and media. They picked this up, but it went out in 3 Canadian provinces and 7 states. And they actually interviewed medical students. So, yep.
Had a comment on there, Dr. Owens. One of our online folks remembers the disaster training day while going to school at USD for dental hygiene.
Yeah. Outstanding.
Anybody else? Any questions online or in the room? Doc Owens will probably be in the hall at the break if you want to visit with him.
Anything we can do to help you out, if it means training, Dakota responder, money for EMT training, help train up medical students, or have medical students help your team train up, we're here.
Just a little bit about the EMT class. Every Tuesday, Thursday night, we televise it out live to the students so they can take the class from the comfort of their home. They don't have to travel. We record all of the lectures. They're available to them in the student portal. The grant covers their textbook, CPR certification, the regionalized lab activities. So generally, we try to keep the students within about 60 miles of their home. So we contract with agencies throughout the state to host the lab sessions. It includes the skills testing. It includes a voucher to take the National Registry exam. It includes a test prep course that we purchase from a third-party entity that helps the students prep for the exam. They have access to the course content for up to the 2-year timeline that they have to take the National Registry exam. So we're trying to make it as convenient as possible and easy as possible. We've got probably in the northeast part of the state, we've got 35 to 38 people that are currently in this particular class. So it's, again, we're trying to keep it easy and convenient, but on the same token is we're asking and emphasizing that the students, their responsibility is to reach out to the EMS agencies in their local community or their local area and make contact with you, you know, at the start of the class so that there's that connection that the agencies are familiar and aware of these individuals in the EMT class and can recruit them into their agency.
Yeah, and Travis, you may want to add on to something I gotta say here. So for Spink County itself, I think we've added 8 new EMTs, and now we have 2, and then adding a third paramedic out of this thing, out of this, how this funding stuff goes. So that's really going to improve our assets in Spink County and surrounding counties. Now, the next trick, this is going to be where things are going to get interesting. To further roll this out, if we get funding, is so certain EMS agencies put on their own courses, and I'm all about that. That's great. The pass rates and whatnot are good. How do we integrate that into this other program, which is statewide? And that's going to take a lot of you folks telling me how to make it work, because I don't know how that's going to work. I know how it works in Redfield, and I know how it works at the Sanford School of EMS, but between those two, because our courses are all taught right there, even though we have the same grant funding. But I don't know how we're going to do that in Webster and Bowdle and Gettysburg. I don't know how we get that to cross match. But Travis is kind of the expert on this grant. And that if we can get some funding from the state, that's our next step, because then we even get better locally trained with state and federal support will be our best outcome. Because once again, I find it ludicrous that we ask people to spend the amount of hours, what's 160 to get an EMT?
160 to 200. Yeah.
Yeah, 160, 200 hours, volunteer, and you got to puke up 800 to $1,000 so you can volunteer, so you can spend 300 hours of your month on call. That's not the way America rolls anymore. So we got to break that cycle and get some support out there. And I think we're getting there. So
Awesome.
thanks very much.
Thank you, Doc. All right, everybody, let's take a break till 10 to 11.